Hi there, I'm Tony Lee, and this is Hot Flasher, your daily menopause podcast that serves up fresh news, research, and wellness tips. I've built a daily news pipeline to find the latest on women's health and menopause research. Allow me to introduce my co-host, Nikki, who handles the headlines. Take it away, Nikki.
Thanks, Tony. We've got a good one today, 3 papers from the NAMS journal, and they're pretty different from each other, so let's get into it. The first one is a nationwide cohort study published in Menopause, and it's asking a question that sounds simple but turns out to have a pretty significant answer. What happens to your cardiovascular risk when you have 2 things going on at once? Premature menopause and high blood pressure. Premature menopause means menopause before age 40. Some women also include early menopause, which is before 45 in this conversation, and the study addresses both. We already know that going through menopause early raises heart disease risk on its own. The thinking is that fewer years of estrogen's protective effect on blood vessels adds up over time. And we know high blood pressure is one of the biggest cardiovascular risk factors anyone can have, male or female. So you'd expect having both to be worse than having one. What this study found is that it's considerably worse, not just the sum of the 2 risks, but something beyond that. The combination appears to be doing something additive, or possibly more than additive, to the risk of heart attack, stroke, and other major cardiovascular events. The study used a national health database, a large one, which matters. So this isn't a small lab study where you take the results and file them under interesting, need more research. This is real-world data from a large population of women tracked over time. The kind of evidence your doctor would take seriously, the kind you'd find on a clinical decision tool like Open Evidence alongside other high-quality sources. My position on this is straightforward. Menopausal age should be a standard question in cardiovascular care for women, and it currently is not. Most women get asked their family history, their smoking history, their blood pressure history. Relatively few get asked how old they were when they went through menopause, and whether that happened naturally or because of surgery or chemotherapy, which also matters. If you went through menopause before 40 and your blood pressure is not well controlled, that combination needs to be on your cardiologist's radar. It needs to be on your GP's radar. You may need to be the one who puts it there, and that's frustrating, but it's the situation. The practical takeaway is genuinely simple. Know your number. Know how old you were when menopause happened. If it was before 40 or even before 45, tell your doctor. Tell them explicitly. Don't assume it's in your chart, and don't assume they're connecting those dots. The second paper is shorter and doesn't have a full abstract available, which limits how deep I can go on the methodology. But the topic itself is worth your attention, and the fact that it's appearing in the NAMS journal at all says something. The paper is titled The Overlooked Intersection of Intimate Partner Violence and Menopause Care. And if your first reaction is, wait, what does one have to do with the other? That's exactly the gap the paper is addressing. Here's why they're connected. Menopause care, even at its most basic, requires things: access to a doctor, the ability to fill prescriptions, privacy at home to take medication or use a product, financial independence to pay for care, and enough safety and stability to actually prioritize your own health. For women in abusive relationships, any or all of those things can be controlled, restricted, or completely off the table. A partner who controls the finances can prevent a woman from seeing a specialist. A partner who monitors her phone can intercept telehealth appointments. A partner who dismisses her symptoms or mocks them or uses them against her can delay care by years. Menopause also overlaps, timing-wise, with a period in many women's lives when relationship dynamics shift. Kids may be leaving, financial dependencies may be changing. Perimenopause itself can affect mood, confidence, and the ability to make major decisions, not because women in perimenopause are incapable, but because sleep deprivation, mood swings, and cognitive fog are real, and they make everything harder, including the very hard thing of leaving a dangerous situation. The paper is calling for menopause care providers to think about this, to ask, to screen, to create the conditions where a woman can actually answer honestly. That's not a radical ask. Domestic violence screening already exists in obstetric care, in emergency medicine. There's no reason it shouldn't be part of the framework for menopause care too. This is a medical system problem as much as it's an individual one. The structure of a 5-minute appointment, a prescription sent electronically, a follow-up by portal message, none of that creates space for a woman to say, I can't actually use this safely. The system has to be designed to ask. And right now, mostly, it isn't. The third item is about fezolinetant, which is the non-hormonal hot flash drug approved in the US a few years ago and sold under the brand name Veozah. It works differently from HRT. It targets a specific pathway in the brain that's involved in regulating body temperature rather than replacing hormones. For women who can't or don't want to use hormones, it's been a meaningful option. This paper is a pharmacovigilance analysis, which is worth explaining because the term matters for how you interpret the findings. Pharmacovigilance is the ongoing monitoring of a drug's safety once it's out in the real world, beyond the controlled conditions of a clinical trial. One of the main tools for this globally is the WHO's VigiAccess database, a reporting system where healthcare providers and patients can flag adverse events, meaning side effects or reactions they think might be connected to a drug. The researchers looked at fezolinetant safety signals in that database and compared them to what the phase 3 clinical trials had found. The broad finding, the real-world profile is largely consistent with the trial data. That's reassuring. It means the drug isn't behaving dramatically differently when used by a wider, more varied population than the people who enrolled in trials. But there are a few disproportionate signals, meaning these events showed up more often than you'd expect by chance, around liver-related events and some neurological events. The study is careful to say this doesn't tell us how common these events are. It just says they showed up at a rate that's worth flagging for further investigation. That's exactly how pharmacovigilance is supposed to work. It's hypothesis generating, not conclusion drawing. What does this mean if you're taking fezolinetant? It means liver monitoring, which was already part of the prescribing guidance, remains genuinely important, not a formality. If you're on Veozah and your doctor hasn't mentioned baseline liver function tests or periodic monitoring, that's worth raising. It also means that if you notice unusual symptoms, fatigue, jaundice, anything neurological that's new, you mention it to your prescriber rather than waiting to see if it resolves. The study's authors are clear that the benefits of the drug for women with significant hot flashes who don't have good hormonal options hold up in this analysis. This is a keep monitoring, stay informed signal, not a stop taking this drug signal. Those are meaningfully different things, and the distinction matters.
Thanks for listening to Hot Flasher. We're back tomorrow with more, so don't forget to subscribe. See you tomorrow.